Good afternoon, everyone. I'm Dr. Michelle Fiscus. I'm the medical director of the Tennessee Department of Health's Vaccine Preventable Disease and Information and Immunization Program, and with me is Dr. Tim Jones, our state medical officer. And I thank you for joining us for this webinar today on updates on COVID-19 and what you can be doing in your practices and for your patients during this outbreak that we're currently facing. Thank you for taking the time to join us. We know that you're very busy taking care of patients and trying to do the best that you can on the ground, working with folks who are sick. We're sure your phones are ringing off the hooks just as ours are, and that this has been challenging for you. And so we hope that the information that we provide for you over the course of the next hour is helpful. Your patients are really counting on you to be there for them right now. They're anxious, just as are many of us. And we really thank you for being there for them, to take care of them, to answer their phone calls. We know you're working harder and faster than what you typically have to do in what's already a challenging environment. Just a couple of housekeeping things. We have 1 hour here together to discuss this topic. We have several hundred participants on the webinar today, and so we're not going to be able to unmute lines, but you will be able to put questions into the chat box for the webinar. We'll get to as many of those during this hour as we can while we're live. And then the rest of them we'll answer in a question and answer document that we'll send out along with the transcript and the video of this call. We're going to try to cover a lot of information, but leave enough time to try to answer as many of your questions as you have. A lot of the information that we'll be covering can be found on our website, which is tn.gov/health. And at the top of that website, you'll see an orange bar there that says for updates on coronavirus. You can click on that bar, and that will take you to our COVID-19 web pages. And those are updated every day. A lot of the information and guidance that we're getting from CDC and from a lot of our partners in public health is updated multiple times a day. And so be sure to check back to that site frequently, as a lot of the guidance changes rapidly. I'm going to go ahead and introduce for you Dr. Tim Jones. He is our state chief medical officer, and he's going to talk to you a little bit about the current situation with the response, and then I'll be back to talk to you about what we can be doing on the ground clinically.
Hi. Before I get into additional discussion, I want to define a couple of terms that you all are probably hearing and that I think can be somewhat confusing for the public and our patients. First, we talk a lot about isolation and quarantine. When we talk about isolation, that is what we do for people that are ill and infected. So if you or anyone has a patient diagnosed with COVID-19, they have to be away from others in a situation where they cannot infect other people. Currently, we're saying for 14 days after their diagnosis. Quarantine is the term that we apply to people who have been exposed to a potential infection, but have not yet developed symptoms. And again, for those folks, it's currently recommended that they stay away from others for 14 days and are very, very attentive to the development of any symptoms, because folks that are at risk, and by definition in quarantine, have an increased risk. We want anyone who develops symptoms to be tested quickly, reported to public health, and have that addressed. In terms of the current situation in Tennessee, this has really only been going on for a few weeks here as opposed to months in other parts of the world. We currently have less than 20 cases, but in other states that have started having cases a few weeks before us, after a week or so of single and double-digit cases, there's a very rapid increase to literally hundreds of cases per week. So none of us should be surprised if the number of cases diagnosed in Tennessee goes up very rapidly. And I think it's important for us to prepare our patients not to be shocked by this, for them to continue to understand that everything that we're doing is controlling the disease as well as can be expected. One of the reasons, I think, an additional contributor to this is that testing is becoming more widely available and restrictions on testing are being relaxed. So obviously the more testing that occurs, the more cases we're going to identify. One of the things that I think we also need to help our patients and the public expect is that as the number of cases expands rapidly, the capacity for responding to it from public health will decrease. So currently, when there is a small number of cases, we have the capacity to reach out to patients individually, to interview them about their contacts, to speak personally to their contacts and get them into quarantine. As numbers rise, we will hopefully always be able to contact the patient themselves, but we're going to have to transfer responsibility to the patients for them keeping themselves isolated. Those folks are going to have to talk to their contacts, recommend isolation for them, and those kinds of things. And that sort of leads to the issue about containment versus mitigation, and again, terms that many of you have heard. Containment is when we have the capacity to sort of deal with individual cases and attack the problem at that level. When community spread becomes more common and it becomes impossible to trace one case to another and who infected whom, we turn more and more to mitigation stage. And that's really what we're approaching now. And that is community-wide interventions. So you will hear later about spacing, canceling events, those type of things that sort of try to decrease the amount of infection community-wide. In terms of resources for our population, there's a public information line. It's being staffed from 10 a.m. to 10 p.m. That number is 877-857-2945, and it's readily available on the Tennessee Department of Health website. And then we have a call center for clinicians set up here at the health department. This is primarily to help try to give physicians some guidelines about testing and to determine who needs to be tested at our state laboratory versus private laboratories. These numbers are all widely available on our website. That leads us to the question about testing capacity. Until a week or so ago, the only laboratory in the state that could do testing for COVID-19 was the Department of Health laboratory. That meant we had to be very judicious about who could be tested and the information that we would gather before the tests were performed. As of this week, commercial availability of testing is greatly expanded, and literally by the day, more laboratories are coming online. So now any clinician can order a test for a patient and it can go to a commercial or private laboratory. And already this week we have LabCorp, Quest, two of the biggest laboratories in the country. Vanderbilt has come online. Many other private institutions are starting to. And in that context, we are really trying to prioritize the testing that is being done at our state laboratory. We don't charge for that testing, but because it is a limited resource, we're trying to target that to patients that are at particularly high risk. So that can be healthcare workers, patients that are on quarantine, and other high-risk populations that may not have access to that resource privately. We're told that currently the cost of these tests commercially is about $300. That turnaround is about 3 to 5 days. Both of those things may change, and my understanding is that insurance companies are reimbursing fully for that. There currently is no outpatient testing. The state does not have test kits that we can send out to providers. The material for doing the test, we ask for nasopharyngeal and oropharyngeal specimens. You can just use synthetic swabs, just like you do for testing for flu and other viruses. Testing can be done safely in primary care settings. Early on in the epidemic, there was discussion about the need to use N95 respirators, potentially in negative pressure settings, but most clinicians now do not have access to N95 respirators, so it's quite safe to do this with droplet precautions, regular surgical mask. It's always good to use eye protection if it can be done. And it's very important not to refer patients unnecessarily to the health department or emergency rooms. Most of our health departments don't even have primary care settings. Emergency rooms are currently being overwhelmed by referrals of patients, even patients that haven't been seen by their own clinicians. And if you don't have supplies, neither does the health department or other providers that you may refer people to. And I think that that sort of comes back to Dr. Fisk's initial point that, you know, as healthcare providers, we really have an obligation to treat our patients. And very often, the most important thing that our patients need are a trusted person to talk to, education, reassurance. 80% of patients have very mild symptoms, symptoms for which 6 months ago they would not have sought medical care. In very many cases, the results of testing will not change the recommendations that are given to patients. And I think that these things can really help you take care of patients, even with the limitations of materials that all of us had. I think it's also very important to set expectations with your patients that do get tested. And again, with current capacity, you know, they will not be able to be contacted within an hour or two of results coming back. In general, results will go back to the clinician that ordered the test. We do not recommend patients getting tested without a clinician ordering it, because obviously if they get the results back, they need someone to help them deal with the results. I think that I will stop there, turn things over to Dr. Fiskus.
Sure, thank you. So a few words about state public health lab testing. You can get testing through the state public health lab, but at this point, because there is commercial availability of testing in a lot of areas, we are prioritizing the testing that's done through our state public health lab to patients who are critically ill, those who are symptomatic healthcare workers or are in other occupations where they might have exposure to large numbers of people, where turnaround time so that we can notify contacts is a priority. For those who are severely immunocompromised or who are residents of long-term care facilities, for contacts of confirmed cases, for those returning from some of the identified high-risk areas, and for hospitalized patients who have ARDS or some lower respiratory illness with an unknown etiology. Generally, the commercial lab turnaround is going to be somewhere around 3 to 5 days. State public health lab turnaround has been closer to 1 to 2 up till now. And we will also do the best that we can here to provide testing for your uninsured patients. So cost should not be a reason not to send testing on someone that you really think needs to have testing for this disease. And then I wanted to spend a little bit of time hopefully giving you some more pragmatic information about what to do on the practice level. So I think the sooner we recognize that this is here to stay for a while and move away from our standard operating procedures and start to adopt new procedures to accommodate the patients and the situation that we're in, the better this will go for all of us. So this will continue to be disruptive. I spent 17 years in practice. I know what the impact of this is for you, and judging by what's happening in other countries, we're probably looking at a minimum of 6 months before things would return to normal, and that's probably being optimistic. So these aren't strategies that we're going to employ for a few days or a few weeks, but kind of the new way of doing things for a little while. So you as clinicians need to develop your own standard operating procedures for your clinics. You can consider canceling elective visits that are in your offices, such as annual physicals, well child checkups, follow-up visits that don't have to be done within a certain timeline. You might consider canceling those, both to give you bandwidth to see the number of patients who might be concerned about illness, but also to limit their exposure to someone who might be infectious. You can consider telehealth as a way of seeing your patients who might need to be seen for behavioral health issues or appropriate follow-ups. Applications like Zoom are free, and that's also a HIPAA secure platform. You can get a Zoom account at no charge and have up to, I think, 3 or 4 participants in that without any cost being incurred to you. And then as far as seeing patients who are ill, a lot of that depends on what resources you have available to you. So we've heard from many of you that you don't have surgical masks, and that's the case in a lot of areas, and they have been difficult to find. I know some of the distributors have canceled orders for especially small practices and redistributed those to maybe their larger customers. We do not have surgical masks to distribute to you either. So while we'll continue to work to see where the opportunities are to get those and send those resources to you, you should also be trying to get those surgical masks yourselves. If you have surgical masks in your office, then you should be able to see these patients safely and be able to test them. If you don't have surgical masks in your clinic, you're going to need to tell people that they're going to need to be seen somewhere else, either in one of the urgent visit clinics, and they should call ahead and make sure that those clinics have capacity, or potentially in an emergency room. But if they're not significantly ill, if they have URI symptoms and they otherwise would not have sought medical care, it's really best for them to just remain isolated at home while they get through those symptoms. It is still much more likely that they have a common respiratory virus than that they have coronavirus at this point. We're still in flu season. We still have a lot of influenza A circulating, along with rhinovirus and the other viruses that we have this time of year, RSV, human metapneumovirus. All of these are being detected in patients who are presenting with concerns of coronavirus. And at this point, less than 10% or so of the patients that are even highly suspect of having coronavirus have been positive. So it's still okay to reassure patients that they should remain home and self-isolate if they're ill, but that they don't necessarily have to have testing emergently. You may want to post signs outside your office and change your voicemail that your patients may be getting to tell them what your situation is, that you don't have equipment and can't see acutely ill people with respiratory viruses, or that you are able to, but you would like them to take the following steps. So maybe you post a sign on your door that says, if you have these symptoms, fever, cough, shortness of breath, or you think that you may have had exposure to coronavirus, that you please go back to your car and call us on your cell phone and have someone take a history from them and determine with that distance if that's someone who might need further evaluation, if they should be encouraged to head home, or whether you're going to be able to accommodate that person within your practice. If it is practical for you to do so, you can leave a box of masks outside the door. I know in a lot of cases that mask box will wander away if you do that, so it may not be feasible for you. You may need to have a staff member walk a mask out to a car and provide it to someone before they come into the office. If you have someone that you suspect may be ill with coronavirus and you have the opportunity to bring them in through a side door or a back door, where you're not having to bring them through your waiting room or through your patient or high traffic areas, then you should take advantage of that. That patient should be masked, as should anyone coming within 3 to 6 feet of that patient, which is what is expected to be the spread of that from those respiratory droplets is about 3 to 6 feet. So if the patient's masked, that will go a long way towards reducing that exposure. If the healthcare worker who's seeing that patient and is in close proximity to them is also masked, then that should greatly reduce any chance of anyone becoming infected with that person's illness. Put them into a room, close the door, and limit the number of healthcare workers or office staff who are being exposed to that person. So if it's typically your workflow to have a nurse or a medical assistant take vital signs and weigh the patient, maybe you forego the weight and go with an estimate or what happened in their last visit. You put them into a room, and the provider who's actually going to be having contact with that person is the one to get their vital signs that day. You can also have people take history from them via the phone while they're in a closed room and that worker is outside of the room, and therefore you avoid the need to put that person in personal protective equipment. People who are going in to have contact with that patient should be in full PPE. So if you're going to be touching the patient, you need eye protection, a surgical mask, or an N95 respirator if you have them, a gown, and gloves before you have any person-to-person contact with that individual, and the room door should remain closed when that patient is in there. If you take those precautions with your staff, you should have very little risk of having anyone on your staff be compromised by exposure to someone who may end up testing as a positive case. What we really want to avoid, and what we know you want to avoid, is having to quarantine your staff because they were not wearing appropriate protective equipment while they were seeing that patient. And we get those calls every day. We saw a patient, we didn't have a mask on them, we didn't mask our worker, and now they have an exposure to a positive case. Now they're furloughed for 14 days and they're placed in quarantine. That's an easy way to end up shutting down especially a small office or practice. So taking those precautions should protect you from having to do that. If you're able to test patients within your practice because you have masks available, then as Dr. Jones mentioned, you want to get one oral pharyngeal and one nasal pharyngeal swab. Those swabs need to be done with polyester or Dacron swabs. They can't be cotton, and they can't be calcium alginate swabs. They must be polyester or Dacron, and they need to be on an aluminum or plastic shaft. They cannot be on wooden shafts. Those swabs then get put into a container of viral transport media, or what some of you might know as the pink stuff. It's probably in your refrigerator. If you do any kind of herpes testing or viral send-outs, that's usually the viral transport media that you have in your fridge that you typically get from your laboratory provider. You put both of those swabs into one container of that to conserve those resources. Put that, make sure you label those specimens with the patient's name and birth date at a minimum. put them in a biohazard bag and put them in the fridge. And then you can either send those out through your contracted laboratory, Quest, LabCorp, AEL, beginning next week, whichever your lab is that you typically use. And you do not need to call the state to ask permission to send that test. You have the ability and authority to make a decision as to whether or not your patient needs to be tested. If you are not able to send a test out through a private lab, either because you don't have access to that lab's telling you that you can't use them right now, or you have an uninsured patient who needs testing, then you can call the state to get an authorization number to send that specimen to the public health lab. As Dr. Jones mentioned, criteria changes pretty much on a daily basis based on our capacity. We were quite strict initially, where we've been able to loosen that a good bit. So if you need a test done, call us. We have actually a room full of people who are here manning the phones from 8 in the morning until midnight, and they can assist you in getting authorization to send that testing in. We'll send you an email with the paperwork that you need to include along with the specimen, and a form to email back to us. And then we work to get that specimen, we work with you to get that specimen to Nashville, to the public health lab, either via a courier, especially if you're in the area, or you may be sending that via FedEx, where we get it the next day. Our lab can accept specimens 24 hours a day, 7 days a week. So if you're driving through Nashville and you need to drop specimens off, you can do that. There's someone there who can take those specimens from you. And we're currently running testing in the state public health lab every day, 7 days a week, often with multiple batch runs in a given day. If we run a test, that assay takes about 4 to 6 hours, and depending on the number that we have, we may be able to have that back that day. It may be the next day before we're able to get that answer back to you. And then know that whatever contact number you give us when you request that authorization, that's the contact who's going to get the lab result back. So if you want to specifically be notified, you need to make sure that we have your contact information, and that the person who's going to get the information about the test is going to be checking their emails over the next couple of days when we release those lab tests. Our results usually come back in the afternoon. Wouldn't expect to see any results from us in the mornings, but in the afternoon you might start getting notifications. And we do that via email to the contact if the case is negative. If they're positive, we'll send you an email, and we'll call the person of record, the ordering clinician, and let them know. We will also notify your regional public health authority so that they can work with you to make sure that that the patient is notified and that their contacts are identified and advised to go into quarantine, and that the patient is appropriately isolated. As Dr. Jones mentioned, I'll just repeat. So if a case is identified, then they are in a 14-day isolation period from the time of their symptom onset. If their symptom onset is unclear, we'll go by the date of their testing. And then they need to be symptom-free or feeling well by day 11 of that isolation period. Otherwise, they're extended by 72 hours from the date that they first appear well. So if they're well by day 11, they're out after day 14. If they're not well till day 14, they're not going to be released from isolation until after day 17. Anyone that goes into quarantine will be quarantined for 14 days from their last contact with that confirmed case. Make sure too that you're having very strict policies around the people who are coming to work for you in your office, and that no one in your office is coming to work when they're not feeling well. They should remain isolated at home. If they have a minor illness, that should resolve quickly, and they should still remain home until they have felt well for 72 hours before they come to work. And that may mean that you're short on personnel, and it may mean that if your main clinician is the one who's not feeling well, that your clinic ends up having to close for a few days. And that unfortunately is the space that we're practicing in right now. But in order to protect the rest of your staff, to make sure that they don't all end up quarantined, and to protect the health of your patients who may be coming to you, it's very important that you not have staff present in your facility if they are not feeling well, and that you have no exceptions to that policy. And then I just wanted to review some general precautions with you as well. So you've heard wash your hands. 20 seconds with warm soap and water and friction is the standard. Do it frequently. Make sure you're wiping down surfaces like doorknobs and desks and phones and keyboards and other frequently touched surfaces to make sure that you're not transmitting virus there. Hand sanitizer that is alcohol-based and over 60% alcohol is fine to use, but it's in obviously very low availability right now, and we're not sure when that's going to become more widely available. So soap seems to be available, and water also, and so that's probably what you're going to need to do. The recommendation is for social distancing. So if you are having or are invited to a gathering where you can't put 3 to 6 feet between you and the next person, then that might be a gathering that needs to be postponed, or one that you may not want to attend, especially if you're someone who's over the age of 60, as that age group is thought to be at highest risk of having complications from this illness. Avoid small enclosed air spaces when possible. For example, public transportation or going to theaters may put you at increased risk, even if there is some space between you. Don't send children to school if they're ill. We do know that children are not having severe symptoms with coronavirus. They may be completely asymptomatic with coronavirus, but yet still able to spread that virus to others. So if your child is unwell, make sure you're keeping them at home. Once we have a case in a school, that school will have to be closed, at least temporarily, while we quarantine the contacts there. So it's the best place for kids to be right now is in school, getting educated, where they're not out in the community with grandparents who they may be getting sick, where they're not congregating in malls and in large groups if they're teenagers, where they're being supervised. And so we would like to keep children in school for as long as we are able to. And given that 90 of our 95 counties are without cases at this point, it would be wonderful if those hundreds of thousands of students could remain in school and not out in the community where they might be getting each other ill. And then avoid non-essential travel. Spring break is coming up for a lot of people. If you have plans to go to a place where there'll be crowds or where you'll be taking an airplane, realize that your chance of becoming ill with coronavirus is probably low, and your chance of becoming ill is seriously ill is probably quite low, but you are at some risk at least of ending up in a quarantine. So remember that any travel that you do may end up extending your stay unexpectedly for another 14-day period. And that again strains the healthcare workforce back here and maybe putting others at risk. So with that, we will open up to any questions that you might have. And I know there are several.
I'll actually start with a couple things. Before we go to the questions, I just want to remind people that our website and the CDC website have the answers to almost every question imaginable. Now, there's so much up there that it's not necessarily easy to find. I do know that it's not very satisfying to our patients to say, look at the website. So I would strongly encourage you all to become familiar with the resources that are out there. Those documents are being changed, again, literally every day. So it's a very good way to keep up to date. Looking at the questions, I'll take about 40% of them, with all of which have to do with something that is a frustration for us as much as it is for you. And that basically it's this idea of you're telling us to wear masks and see these patients. We have no masks. And where do you expect us to send them? Was one of the ways it was phrased. there is no good answer to this, but I think it's really important for your patients and for you not to just send them in a frustrating circle of unsatisfying communication looking for answers or the right answer that they're not going to get. And that's, I think, to Dr. Fisk's point earlier, that at some point we as a provider, we're the ones that ought to take responsibility for helping them to understand as much as we can. So we're hearing about many clinics that are just putting a sign on the door saying, if you think you have COVID, go to the health department, go to the ER, or go to another clinic. Your partner across the street or your local hospital, if you know that they can't do it, we really need you all to help talk to the patients and educate them and sort of triage only the most important and at-risk patients to get that test. And then if you don't have the masks, and neither do the clinicians across the street, you've heard about things like literally seeing them outside, talking to them while they are in the car, having very specific providers and rooms that will accommodate those patients. One of the questions was about what do you do with a room after a patient has left. Widely available sanitizers that you can get, anything that's FDA approved and that you can get at the drugstore, work well against this virus. I wish we had a better answer, but we're just really asking you to help educate and triage our patients in the most kind and appropriate way that we all can. So we'll take them one at a time, and we'll try to give quick answers because there are a whole lot of questions.
Okay, so recommendations for primary care providers over the age of 70, or we'll actually say 60 because that's the risk age, in terms of temporarily limiting their practice. That depends on what your practice situation is. If you're in a small local practice, you probably don't have an option to temporarily limit yourself. If you're in a larger practice, you may have an opportunity to do that. If you cannot, then I think all of those triage things that we discussed, putting in place a policy where your patients are asked to mask before entering the clinic. They're asked to go back to their car if they're symptomatic and call in. That may involve you having to have someone dedicated on the lines who can answer those calls. And then making sure that you're masked if you're going in to see patients. You may want to mask to see any patient that's coming in with URI symptoms. But as far as our understanding is about the spread of the virus, you should be able to feel fairly confident that you'll be okay if you're masked, and especially if you mask that patient as well during that interaction. You're likely going to be at low risk for contracting the illness. We have so a question that says, with regard to quarantine, if you have multiple providers in a certain situation where staff are potentially exposed, then what are offices supposed to do? So if your office has seen a confirmed case and you have workers who are within 3 to 6 feet of that patient and were not wearing protective equipment, and that patient was not wearing a mask, then those workers are going to need to be furloughed for 14 days and quarantined and monitored for symptoms. Unfortunately, in a small clinic, that can mean closing for a period of a couple of weeks because of that exposure, which is why it's so critical that you're informing your patients before they come inside that if they have those symptoms, they need to have a mask on, and that your staff know that if they're going to come in close range with those patients, that they also need to, at a minimum, have a mask, if not be in full PPE, if they're going to have actual contact with that patient. And then once a patient's been seen in an office and a test is ordered, but you don't know the result, what do you do with the room? I think Dr. Jones covered that to an extent. So, if you can give it a little airtime, that's great. Wipe down the surfaces. We know that in some really busy clinics where they're seeing lots and lots of people, you may not be able to put a lot of space between patients going into rooms. But if those patients are masked and you wipe down the surfaces, that's probably the best that you're going to be able to do.
The next question has to do with how many patients are being tested by the state daily. I got one approved yesterday, but it took me about 20 minutes. Currently, we are doing about 20 daily. Again, with private laboratories, we think that number will go far, far higher. Lost the second half of the question. Getting approval. You heard that we have many, many people answering the phone, but we are also getting hundreds of calls behind. So we'll do our best to approve them, but private laboratories do not require any kind of pre-approval. And so for anything other than uninsured or high priority patients, that's a much, much easier way to go.
So to confirm, the swabs that you need to get are one nasopharyngeal and one oral pharyngeal. So nasopharyngeal means you're getting it way back there, not just in the nostril. Oral pharyngeal, both on polyester or Dacron synthetic swabs with plastic or aluminum handles, not wood. And then both of those swabs go into viral transport media, which likely you have on your premises if you ever run herpes tests or any other kind of viral testing. And then both those swabs can go into the same viral transport media, so we can conserve that resource. And then that's what's sent to the lab. Turnaround time for commercial labs is probably somewhere in the 3 to 5 day range. With the state lab, it should be more like 1 to 2 from the time we receive the sample. So that may be another day for you to get the sample to us. And then I saw something about, I'm blanking on that now. So I will go on. If a patient can't afford to have the test, so assuming that they are uninsured, because we've been told that all insurance will pay for testing, then you can send that test to the state lab. You just need to call the provider number to request that authorization. That number is 615-741-7247. 615-741-7247 is the number to get authorization, and there are people here to answer those requests between 8 and midnight each day, 8 a.m. and midnight each day for right now. We don't run those tests 24 hours a day, so after hours you can put that lab test into your refrigerator, and you are welcome to call in the morning, and we can arrange, work with you to arrange getting that transported to the state public health lab.
We have a question about HIPAA compliance with Zoom and those kind of things. There are so many services that we can't really opine about any specific ones. I think you just need to use your judgment there. That I would say in a situation like this, you are very unlikely to get criticized for using these kind of mechanisms to handle your patients, and it's much more dangerous to just not communicate with them. Will telehealth visits be paid by state insurers? My understanding is yes, at their normal rates, and that includes Medicaid. Why don't we go to the next page? I think we've answered this.
And then we just had confirmation too that we've had some physicians saying that LabCorp is not accepting samples. We've just verified that with LabCorp's head of nursing. Sorry, that was our head of nursing. Verified with LabCorp that they are accepting samples from across the state for COVID-19 testing, and you may need to be a contracted provider with LabCorp to use that service, but they should be accepting samples for testing.
That may change by the hour, so we encourage you to call, but again, unfortunately it doesn't change the advice here. Please elaborate on what you're considering high-risk areas for travel. We'd encourage you to look at the CDC website, again, because that changes almost daily. The list of international travel sites clearly there right now for in-country travel, interstate, parts of Seattle. Correct me if I'm wrong. What else is on the list? Part of the problem is this is changing so quickly, and it can even be parts of cities. Very soon, I guess the short answer is very soon this will be moot, because cases are occurring in so many communities and so many states that trying to determine, which area is more at risk than another, it's really going to become virtually impossible. And I think you just need to discuss with your patients about their own personal risk, knowing that this virus could be in any community that they visit.
Someone's asking for clarification about PPE, that most offices don't have eye protection and gowns and masks and gloves. So certainly all offices should have gloves. Many have gowns that they put patients in that can be used to help protect your clothing. You should have eyewear that you can wear if you're doing any kind of procedures in your office. If not, big box chains have goggles and eyewear that you can get. I think the rate limiter here is the surgical masks. That's the thing that has been in highest demand. And so if you have patients that you think may have coronavirus, then you need to have at least a surgical mask on. And so, correct, if you don't have access to surgical masks, then you may need to defer those patients to another provider in order to have them evaluated, and so as to prevent your staff from ending up in quarantine because of an exposure.
There's a question about, seems unlikely that most practices will be able to assess these patients, and are there plans to set up regional screening facilities? We've addressed that first statement. Unfortunately, most practices really do need to figure out ways to be able to assess these patients. There are a couple of facilities that we're aware of, particularly large hospitals that are setting up large throughput sites, dedicated sites to see and treat these patients. We can't control which institutions do this, but I would strongly encourage you as providers to contact your local hospital and talk to them about ways that might be done in your community. And if you all can work together to have that done in your communities, I think it will alleviate many of the concerns about testing that you all have raised.
So there's a question about what is it about COVID-19 that's triggering such a significant response across the country, and how is that different from the 2009 H1N1 pandemic? So the biggest concerns here are that this seems to be potentially more infectious than what H1N1 has been, and that the mortality rate is probably at least 10 times what we saw with H1N1. And if you'll recall, H1N1 killed about 500,000 people in that season. So if we're looking at 10 times that at a minimum, we're looking at 5 million people at a minimum. And so that's what's brought on a lot of the concern about that. Another question here is our emailing results HIPAA compliant? It is, because we do it with a person under investigation number and not any identifiable health information.
There's a question about what to do with patients that have URI symptoms but aren't tested. Basically, we give the same advice that you would give to anyone with any other viral illness, flu, colds, whatnot, which is you've still got to stay away from other people until your symptoms are resolved, and generally we would say 24 to 48 hours, but you use your judgment on that depending on the social situation of the patient and who they may be exposing.
There's a question about a specific contracted lab. We have not seen any guidance from labs, commercial labs, other than LabCorp, Quest, and AEL at this point. So we're not, unfortunately, able to comment on any of the other contracted labs where there might be questions about their ability to test.
how to assess, people with overlapping symptoms like allergies. I can't answer that question for you. That's sort of the clinical judgment, the kind of call that we just have to deal with every day. Lingering cough for days after symptoms have resolved. People are, for what we know now, and we're always gathering data, we do not think that people will persist in being infectious for 30 days after they get this disease. So we generally would say 3 days after symptoms resolve, but if someone is diagnosed, we would say 14 days currently, 14 days after the date that the test was done, they should be okay. And that's a little, I guess that would be for people that have, the 100-day cough, or smokers that are coughing. I would check the website for changes in that guidance, but I think for now that's reasonable.
So when we're saying avoid mass gatherings, they're asking if the recommendation is for everyone or if that's for high-risk people. It's really for everyone, and especially for high-risk people. So, we can't tell you that 50 people in a gathering is safe, but 51 is not, to give you a number of what's reasonable. But if you can't put a space between yourself and the person next to you in a mass gathering, then it's probably best that you're not attending those at this point. There's a question about co-infection with COVID-19 and influenza, and if all patients who are positive with influenza should be tested going forward. Your chance of having COVID-19 is still very low, much lower than your chance of having influenza. Your chance of having influenza and COVID-19 is exponentially lower than having one or the other. So you can use your own best clinical judgment as to whether or not you think you should also run tests for every patient who comes into your clinic with influenza for COVID as well. But that should be a very, very small number of people that would have both infections.
I would say very small. And you will save your patients a whole lot of money if you do a flu test first, $20 or $30 to eliminate the need for a $300 test if they actually have the flu. Does Lysol or Clorox kill this bug? Probably not, spraying a can around the room, but Clorox or FDA, EPA-approved products you can actually put physically on surfaces should, yes.
And those are listed on the CDC website. There are lists of approved cleaners on there. How do you recommend we manage homeless people under investigation with pending testing who may be difficult to contact or follow up after discharge from an emergency department? It's a huge problem as it is with people who are homeless and have hepatitis A or any of the other contagious diseases that we see. So you have to do the best that you can to figure out where those people hang out, and you can also contact public health to have them see if they can assist you in finding those people to give them positive test results. It's a difficult situation, and we do the best that we can to help them. Right now, there is not great evidence that Tamiflu helps. There are some studies coming out, and we do hope to have an antiviral sooner rather than later, but I don't think there's been great information yet on exactly which one that's going to be, unless you've heard something different.
We've only got 5 minutes left, so we're going to go to very, very short answers and new questions. Are we recommending closure of religious services? We can't say to do that, but I will tell you a whole lot of churches are doing that now, saying that they will reassess every week or two.
The things that should be considered with religious service, though, are obviously communal cups should be avoided. Elderly people who are the door greeters or the ushers who are making contact with lots of people. Very crowded churches might need to consider reducing those numbers or spacing.
Let's go to the next page. Dentists, same advice for physicians. Asymptomatic, schools. Right now, a lot of schools are closing. Dr. Fiskus already mentioned the fact that there are risks as well as benefits to that. We are discouraging closure of schools just because there's a case in the community with a school that has a confirmed case in it. There may be some reason to do it for a short period of time while their direct contacts are being investigated.
Someone has asked, staff who come into contact with patients who test positive should be quarantined for 14 days from the contact, but they're not finding out results for 5 days. So that, and then those staff are then exposed but have continued to work. So the general thought about incubation of this virus is somewhere around 5 days or so. Hopefully we'll have turnaround time to get people isolated or quarantined as soon as they know that they've come into contact with someone. You obviously don't want to have to furlough your whole staff every time they come into contact with someone who may or may not be a case, because chances are they're not going to be a case. But the best way to avoid that problem is to make sure that anyone coming into contact with someone who has COVID-like symptoms is appropriately masked, as is the patient, and you won't have to worry about that.
And I think we're running out of time. We'll probably have to take just one or two last questions. This is an important one. What about pre-symptomatic transmission? We're collecting data on that, obviously, around the world. There was one report a couple of weeks ago that seemed to be the case, but that was probably not a reliable report. So right now, there's no good evidence that there is asymptomatic transmission. We would strongly encourage you not to do testing on asymptomatic people and to talk to your patients about the most important issue of all, which is if they have symptoms, do not do anything else that would expose other people.
I'm going to repeat 2 phone numbers for you. One is for the public information line that's open from 10 a.m. to 10 p.m. 7 days a week. That number is 877-857-2945. As we said before, your patients would rather hear from you, but if you need to give them a resource, they are welcome to call that line. For clinicians who are looking to obtain authorization to send a test to the state, that number is 615-741-7247, 615-741-7247. And again, if you are sending a test to your commercial lab, you do not need to call the state for authorization to do that. Please use your own judgment and leave the lines open for people who have uninsured patients or patients that are one of those really high-risk categories, so that we can do our best to help them with testing. So with that, we thank you for your time and attention. We will be sending out the slides, a link to the video, and we will compile a question and answer sheet for you as well, so that you have that information, and we should have that out to you first of next week.